A story from Surat, the first signs of a crisis. It was September 1994. The city of Surat in Gujarat was bustling, as it always was. Then, a strange and frightening illness began to surface. People developed high fevers, painful swollen lymph nodes. Fear spread faster than the disease itself. Within days, the city's vibrant streets fell silent. Shops shuttered their doors. A mass exodus began, hundreds of thousands fleeing an invisible enemy. This was the Surat Plague Scare. It was a moment of national panic, a stark reminder of an ancient disease making a modern comeback. Doctors, nurses, public health teams raced against time. They worked day and night, often with limited resources. They had to quickly identify the cause, treat the sick, and stop the spread. This situation was what we call an outbreak. The Surat crisis, though terrifying, was eventually brought under control. It became a powerful lesson for India's public health system. It showed the world how critical it is for doctors and medical students to understand the principles of disease outbreaks. To fight an enemy, you must first be able to name it correctly. In public health, words have very specific meanings. They help us understand the scale of a threat and coordinate the right response. We often hear the terms used, sometimes interchangeably. An outbreak happens when a disease appears in greater numbers than expected in a community or region. If that outbreak grows within a country, it becomes an epidemic. When it crosses international borders and affects many countries, it becomes a pandemic. Think seasonal flu or malaria as endemic, the 2014 Ebola crisis as epidemic, COVID-19 as pandemic. The key factor is geographical spread. An endemic level calls for routine surveillance and management programs. An epidemic triggers rapid investigation teams and contact tracing. A pandemic requires global cooperation, travel restrictions, and large-scale manufacturing of vaccines. For a doctor, knowing whether they are dealing with an endemic surge or the start of an epidemic changes the questions they ask, the tests they order, and the urgency with which they report findings. Understanding this vocabulary is not just academic, it dictates action. To prepare for the future, we must look to the past. The history of pandemics is long and often tragic, but filled with crucial lessons. One of the earliest and most infamous pandemics was the Black Death, caused by Yersinia pestis. It swept across Asia and Europe in the mid-14th century, killing an estimated 30 to 60% of Europe's population. Centuries later, as World War I drew to a close, the 1918 Spanish flu infected about one-third of the world's people, devastating populations including India, where the death toll was catastrophic. It taught the world about the power of a novel respiratory virus and the importance of public health measures, however basic. The jet age spread. In 2002-2003, SARS, a novel coronavirus, jumped from animals to humans and reached more than 24 countries, a wake-up call for international surveillance. Beginning in late 2019, COVID-19 redefined the modern pandemic. Unprecedented lockdowns, strained hospitals, and rapid vaccine innovation like mRNA. Each pandemic, from the Black Death to COVID-19, left indelible marks, offering timeless insights for those who will face the next one. Next, how these lessons played out in India, from Surat to chikungunya and beyond. India, with its vast population and diverse geography, has a long and complex history of battling infectious diseases. These experiences shaped public health infrastructure and provided invaluable lessons. The 1994 plague outbreak in Surat was pivotal. While it caused fear and economic disruption, the response demonstrated rapid mobilization. Containment relied on aggressive public health measures, vector control, and case management, lessons in sanitation and surveillance. Chikungunya re-emerged in 2006, and dengue surges during monsoon seasons regularly overwhelm hospitals, highlighting environment sanitation public health links. Following H1N1 in 2009, India integrated surveillance, set up isolation wards, trained staff, and strengthened testing, capacities that helped during COVID-19. COVID-19 tested every level of health infrastructure, but also spurred mass testing, temporary hospitals, and the largest vaccination drive in human history. Healthcare workers faced immense risk and fatigue, but crises also drove innovation and collaboration. For medical students, participating in these responses has been an unparalleled learning experience. Real-world lessons in epidemiology, crisis management, and public health. How do we know an outbreak is starting? The answer lies in surveillance. Public health surveillance is the ongoing, systematic collection, analysis, and interpretation of health-related data, the nervous system of public health. Passive surveillance is routine reporting by hospitals, clinics, and labs. It is essential but can be slow and incomplete. Active surveillance is proactive. Teams go door to door or review records to find cases and understand the outbreak's true extent. Sentinel surveillance uses selected sites to provide regular, high-quality data representative of a broader area. Efficient for diseases like influenza. Syndromic surveillance tracks symptoms and non-traditional data. Spikes in OTC cough medicine sales or school absenteeism can be early signals. India's Integrated Disease Surveillance Program, IDSP, connects districts to a central unit, enabling faster detection and response. For doctors, timely and accurate reporting of a single unusual case could be the first critical signal that a new outbreak is underway. Early detection is everything. It provides the crucial window for officials to act swiftly and decisively to contain a threat before it explodes into an epidemic. In the world of epidemics, one number often gets more attention than any other: R0. Simply put, R0 is the average number of people one sick person will infect in a fully susceptible population. If R0 is 3, each infected person infects 3 others. Those infect 9, then 27. Exponential growth. If R0 1, the outbreak grows. If R0 1, it will eventually fizzle out. Public health's goal is to push it below 1. R0 is not fixed. It depends on pathogen traits, transmission mode, environment, and human behavior. Measles has a high R0, 12 to 18. The original SARS-CoV-2 was around 2-3. Knowing this guides the intensity of controls needed. Vaccination, masks, distancing, isolation. These reduce the effective reproduction number. Together, they break chains of transmission and drive R below 1. When effective measures work, transmission declines and communities recover. Understanding R0 helps public health plan and act. During an outbreak, doctors are more than clinicians treating patients. They become the eyes, ears, and hands of the public health response. First duty: diagnose and treat, manage complications, often under immense pressure and with limited resources. They are legally and ethically obligated to report suspected notifiable diseases. A doctor's suspicion can trigger an investigation. Medical students can be mobilized under supervision to help with education, data entry, contact tracing, and simple clinical tasks, invaluable learning and support. Outbreak response requires teamwork, clear communication, and resilience. When an outbreak is suspected, teams follow a systematic sequence. First, confirm that an outbreak is actually occurring. Next, establish a clear case definition, clinical signs, lab results, time and place restrictions, so every case is counted the same way. Then, actively find and count cases, line listing everyone affected. Describe cases by time, place, and person. Draw epidemic curves, map clusters, formulate hypotheses about source and transmission, then test them with analytical studies. Simultaneously, implement control measures, communicate findings to the public and clinicians, and maintain surveillance to ensure control measures worked. Control measures depend on how a pathogen spreads, its severity, and available resources. For respiratory viruses, masks, ventilation, distancing. For foodborne illness, identify and remove contaminated sources. For vector-borne disease, control mosquitoes and remove breeding sites. Vaccination is a powerful tool. Alongside vaccination, infection prevention, hand hygiene, PPE, safe waste disposal is critical. Preparedness means training, stockpiling supplies, strengthening labs, and having clear communication plans so trusted information reaches the public early. Community engagement builds trust. When people understand risks, they follow public health advice. 1. Act fast. Early detection saves lives. Always report unusual clusters immediately. Your observation could be the first signal. 2. Follow the steps. Outbreak investigation is a science. Learn case definition, line listing, analysis, and control. 3. Communicate and protect, build public trust, and use proven public health measures to safeguard your community. Please take a moment to download the handouts for this session, which include a quick checklist for outbreak investigation steps. Then test your knowledge with the short quiz. Be prepared. Keep learning. Be ready to serve when your country needs you most.